So without any further ado, it's my very great pleasure now to welcome Dr. Jennifer Dixon, Chief Executive of the Health Foundation. Full biography on the site that I've just directed you to. Please put your hands together and welcome Jennifer Dixon.
Thank you. Thank you, Bill, and a very big welcome. I'm so pleased that we support ISDG, and it's great to see so many familiar faces, and I'm really looking forward to the conversations we're going to have on this very important topic of resilience today. When thinking about resilience, my mind was actually cast back to a paper that I read, it must be about 10 years ago now, and this paper was by Bob Evans, whom some of you I think know, a Canadian economist. And Bob was writing a paper in the Journal of Health Policy, Politics and Law, and he was writing a summary paper in response to a whole set of papers on the latest developments in reform across European healthcare systems. And what Bob was trying to do is to look at patterns across the developments in health systems across Europe. And one of the things that he said sort of struck me quite considerably. One was that he noted what were two phases, as he said, in health system reform. One phase was the original setup of health systems in Europe as a result of political pressure and the craving for security resulting from the Second World War, or arising around that time. So many health systems at that point were set up for universal coverage. And with Southern Europe setting up theirs later, once they'd overthrown their authoritarian regimes, probably in the 60s and 70s, Spain and so on, Greece. So that was phase one. And then he noticed that so there was a kind of expansionist phase between the late 40s and the 70s. And then came the oil shocks, significant sort of financial challenge that arose from that. And then there was a position where the search was on for much greater efficiencies in order to protect the gains in quality that had been made, but also to protect the social settlement that had been set up after the war. And he said that that phase, as he was writing in 2005, had kind of extended to 2005 from the 70s. What he did not see, of course, was the financial crash of 2008. And what then ensued later, particularly for not just for the real straightened economies in the Eurozone, but for ours, where we see now a long, long period of austerity into the future, where we are expected to be making significant productivity gains every year in order to cope. And for those of you who are particularly interested in, I think probably one of the, dare I say it myself, one of the best analyses of the trends and the productivity challenge upon us, we published last week 5 briefing papers on this, which have been picked up in the press by our economics team, which I think are a really good analysis of exactly what is facing us. And let me tell you, it's not just 1 or 2 years, it is for the foreseeable future. So under those circumstances, resilience is needed, absolutely, but it's not just resilience, it's resilience plus. The plus being the creativity on top of resilience that we now need to get us to sustain ourselves as a system. So what kinds of things are now needed? Well, let me tell you where I am, and you will think about this more deeply, so I'll just give you some headlines of where I think I am and we are at the Health Foundation. The first obvious thing I think that's now needed is that we don't have an overarching narrative, in England I would say, I think it may be different in Scotland, as to what makes improvement in a complex system like the healthcare system. We know a bit, but we don't know a lot. And those who are shaping this health system, particularly those at a national level, I don't think have a common narrative about what makes for change. So I think that's point number one, and it's a simple point, but don't underestimate it. The second point is I think we need a much more intelligent blend of policy levers to help encourage improvement at the front line. That's the obvious point too. At the moment we do not have a cocktail that is probably coherent. In fact, it may be resilience reducing. So that's the next stage I think that is needed, and that is in itself is a huge, huge task to to create this blend, whether it's payment reform, whether it's command and control, whether it's a regulatory system, whether it's the extent of competition, that needs to be crafted through time to help support the front line. And then the third area, and this is where I do descend into more platitudes, so forgive me for a minute and stick with it. I think really those at the top don't always understand what happens under the skin of providers in order to make for the kinds of changes that we surely need to see at the front line to make change. In a sense, the physiology under the skin of the providers is really murky, I would say, to some of those, particularly in England, who are at the top. And there, I think we have to sort out the murk for them. And again, to be very simplistic, what needs to be done at this layer? Well, one layer is, of course, have leaders who understand what makes for improvement and who can create an atmosphere and a culture inside organisations that is conducive to change. The second layer is to have decent management processes that can effect change and support change, particularly at the front line. So much, as you've heard of in the past, and Nick has certainly talked about this, so much is chaotic where it should be ordered. Simple processes are not being carried out, which drive clinicians at the front line nuts because they can't carry out and they waste time. So that management layer, again, easy and glib to say, but there's a lot of infrastructure work that needs to do to bolster that. I suspect Stuart Rose, in his analysis, that's the former chief of M&S, who's doing an analysis of the NHS and is about to produce a report. I suspect he will focus on that management layer. And then, of course, the layer that we are more familiar with, which is what I call rather simply quality improvement skills at the front line. We know that the clinical community, the number of people in that community working in the National Health Service who have those skills is patchy, to say the least. If we believe these skills are important, how best to colonise the system more effectively at a pace that we haven't seen before? So those are some of the challenges. There are many more, but that's a sort of way of thinking about them that I think we're concentrating on at the Foundation. So how does this affect ISDG and your discussions here? Well, I just want to put to you, just by ending my introductory remarks, by just posing a few questions, which I think are on my mind and maybe are on yours. But I think that your brains on this could I think, help quite considerably now. I think the first question is there enough evidence that practical QI skills at the front line are producing benefits for patients? That's a very basic question. Do we have enough evidence to convince that that this can provide forward momentum? What characteristics of context matter to allow quality improvement to flourish? And is our perspectives on context document that we put together, is that enough to go on for the moment? Or are we missing something? Third, can we rapidly assess the QI capability at the front line and the context in all the providers across the country? In other words, if we were to develop could we develop a barometer where we could dipstick into providers to produce a map of where is their fallow soil in QI across the country? Where is the context hostile? Where are the no QI skills? And conversely, where are there some skills that can produce change? And we are working on this at the Foundation with a piece of work. If QI capability in providers is low and we believe it's valuable, how best can we develop that capability fast? And here, some of the developments that the Foundation are involved in are designed for this purpose. The UK Improvement Alliance, you've heard about, our alliance with NHS England to develop 5,000 quality improvement fellows across England, our work with AHSNs to try and boost capability, growing capacity. Is quality really better in those providers with a good context and high QI capability? What's the correlation of quality as measured with current metrics and QI capability, if I can put it so simply as that? How far does QI capability at the front line, how far is it able to not just produce useful interventions, implement useful interventions such as the sepsis bundle, and to what extent at the other end of the spectrum can it be useful for delivering large-scale service change of the type mentioned in the 5-year forward view? Do we know? And indeed, how far could QI skills be used to further the health agenda, not just the new models of care agenda? When is it possible to rely on small groups to make change, and when is a more collective effort more effective, such as using collaboratives or other networks? How best to measure improvements? You had some of this yesterday. There's a methods issue, there's a data issue, but how better could we produce more convincing evidence of impact with these complex adaptive changes that we need to see? And more fundamentally, I really will stop this long list of questions, more fundamentally is what would be the contours of an intelligent improvement strategy be for England? I say England because Scotland have an intelligent improvement strategy as far as I can see. What would it look like for England now, given where we need to go in the next 10 years and the squeeze that's on us? So those are some questions that are bothering us. That's affecting our agenda at the Health Foundation. But I'd like to leave you with one question, which I think is a recurring question that we've had in this group over the last at least year or so. And that is, what role do you as a group want in helping to shape the agenda along these lines into the future now as an entity? Do you want to be a loose network of people who discuss interesting things and pursue your own goals? And to what extent do you want to come together as a collective to try and shape some of this agenda from the very top at national level down to some of the more nitty-gritty, researchy type of questions and practice questions that I've outlined? And where are your thoughts here in terms of developing an academy? Do you want to go for that? And if so, how can we best support you to do that at a time, as I say, when the system needs it most? So if I can plant that on your tables, that you will hopefully have time to discuss, at least over a sandwich. I hope that's very helpful. But anyway, thank you for listening, and I really look forward to the rich discussion we're going to have. Thank you.
Jennifer, thank you for a wonderful start. I love the idea of this contour map that we're going to be creating, essentially, and it's almost an ecological metaphor that I think we're perhaps grappling toward in part of our understanding of resilient systems. And we're now going to move on and start our next section of this conference with two leadership perspectives. So our first speaker will be General Sir Richard Shirreff. His full biography is on the conference website, and he was Deputy Supreme Commander NATO Europe between 2010 and 2014. And then Jan Filchowski, who has been very much involved in leading health service organisations. We'll tell you more about that in a moment. And then we'll have a more ruminative conversation, and then we'll stop for a refreshment and more conversation and return to go deeper with some of those ideas. So to start off, please, colleagues, would you welcome General Sir Richard Shirreff to give us his view of leadership? Richard.
Well, ladies and gentlemen, self-evidently not in any way a health professional. Empirical experience of the A&E department in North Hampshire Hospital, my wife, my daughter, and myself on one particular day a couple of weeks ago, and all I can say is that we were treated superbly. So much of the flack, I think, that let me push back on some of the flack that you're getting, that the health service is getting in the media anyway. Listening to Jennifer Dixon on the challenges that you face, and very conscious of the extent to which the NHS appears to be increasingly a political football used by all parties. I wonder what it feels like to be weaponized by Ed Miliband. I'm not sure that sits easily with the Hippocratic Oath either. I think it's worth recalling the words of the 26th President of the United States of America, Theodore Roosevelt, in a speech he gave at the Sorbonne in April 1910. "It's not the critic who counts," he said. "Not the man who points out how the strong man stumbles or where the doer of deeds could have done better. Credit belongs to the man who is in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, and who comes up short again and again. Because there is no error without effort or there is no effort without error or shortcoming. But who actually strives to do the deeds? Who at the best knows in the end the triumph of high achievement? and who at the worst, if he fails, at least he fails while daring greatly, so that his place shall never be with those cold and timid souls who know neither victory nor defeat. Well, that is the essence of soldiering, and I suspect the essence of being a doctor, a nurse, or a health professional, or indeed any worker in the National Health Service. So it's a pleasure and an honor to be with you, the men and women in the arena, the doers of deeds, as you face the daunting challenges ahead. Well, I've been asked to say something about my leadership journey and what it's taught me. All I can do is to lay out my stall and give you some observations based on 37 years as a professional soldier, with a fairly typical record of service in peace and in some wars. I'll talk about my motivation for becoming a soldier and what my time in uniform has taught me about leadership at the front and beyond. I'm very conscious here that I'm heading into well-trodden ground. Since its foundation in 1923, the Harvard Business Review has published some 800 articles on leadership, of which over 600 have been published since 2006. So there's clearly been an exponential increase, at least by academics, in the study and writing on leadership. But let me go back to the start of my journey. When I went up to Oxford, I'd intended to become a lawyer. But meeting and talking with people who had done gap year commissions or were on in-service degrees from the Army reignited a boyhood passion for matters military. And I wanted excitement. I wanted challenge, both physical and intellectual. I wanted adventure, and I wanted the chance to command soldiers in action. And self-evidently, I was not going to find that in the law. Did I understand that the profession of arms was not so much a profession, but a way of life? Well, probably not at the time. But things changed pretty quickly once I joined. And it all starts in the grounds of the Royal Military Academy, Sandhurst. For there you will find the essence of the ethos of the British Army. Everywhere, most notably perhaps in the Memorial Chapel, you will see evidence of that ethos which sets the British Army apart from every other army in the world. And the foundation of that ethos is leadership, for it is good leadership which inspires, underpins, and enables all the other capabilities of the British Army. And not for nothing is the Sandhurst motto, serve to lead. For leadership is at the heart of command, and command is at the heart of being an officer. But what do I mean by leadership? Well, to me, leadership is about getting people to do willingly and well what we as leaders want them to do. It's about who you are and what you are. It's about individual character. And it's therefore intensely personal. We're all different, so we all approach it in different ways. And in my world, it means recognizing that soldiering is a vocation and that leadership is a privilege. And only if you have a passion for soldiers and soldiering, a desire to serve your soldiers, and the ability to inspire and communicate, will you be able to connect with the men and women you command. What does it need? Well, we could all come up with a long list of characteristics a leader must have. I'm just going to highlight three that I think are particularly important at the front, as it were. Trust, courage, and robustness. Fundamental to command is trust, upwards, sideways, and downwards in the organization. You can't ask others to risk their lives unless they trust you. And trust takes time to build. Much of it comes from living, from working, and from playing, whether sport or partying or socializing together in an organization. And of course, service on operations, or particularly in combat, builds trust more quickly than anything. But the bottom line is this: it comes from competence and the confidence that people have in you that you can do your job. And competence is based on experience, training, professional study, and thinking, always underpinned by character and flair. I'd highlight courage next, because courage defines leadership. The first virtue, because from it flow all others, as Churchill put it. And physical courage is the true knightly virtue to which all soldiers aspire. And rightly, we expect physical courage from our officers, the courage to take action, the courage to lead by example when circumstances demand it. So leadership from the front and by example is the absolute essence of warrior leadership. putting yourself in danger, putting yourself, and not expecting others to do things which you are not prepared to do yourself. But equally important is moral courage. The courage to make and stick with difficult decisions, especially when they will be unpopular. And at the senior levels, the moral courage to speak truth unto power is fundamental. So ultimately, leadership at the front requires the courage to put life, career, and reputation on the line when necessary. Next, I would single out robustness rather than the Army's other core values of loyalty, integrity, discipline, respect for others, and selfless commitment. Now, not because they're not important, because they are. Indeed, I would say that they're not just moral, in an organization like the Army, they're not just moral nice-to-haves, they're absolutely functionally and operationally indispensable. And that's a question, I think, that all organizations need to think about as they look at themselves. But coming back to the point, robustness, or you could as easily call it resilience, both physical and mental, is about that ability to take the knocks when things get difficult and to bounce back undeterred. It's about making things happen by sheer force of will, translating that will into action. And it's also about coping when things go wrong, as they invariably will at the worst possible time, when the effect on others of a strong physical presence emanating confidence and optimism is really important. But leadership requires more than core values. It needs the spark, the catalyst, to turn these ingredients into leadership. And that spark is the ability to connect with people, to communicate, and you could as easily call it inspiration or charisma. And you can only connect with people if you can understand their needs, understand their fears, and you can reassure them through your own strength of character that you have their interests at heart. It's about EQ, not IQ. And to communicate, you need to talk to people. You need to look them in the eye, and you need to ensure that they understand, that you understand what you're talking about. And I've learned that there are you don't need to be an orator, but you do need two things. Number one, you need to know what you're talking about. And the second thing is, you've really got to believe what you're talking about. Let me finally highlight a couple of other things which I think make it easier for us in the organization that I've just come from. The importance of morale is first. And Napoleon was right when he said that the moral is to the physical as 3 is to 1. If people know they have the capability to cope with difficult situations, it's easy to lead them. If morale is high, people lead themselves. And morale is a state of mind, that intangible force which will move people to give their last ounce without counting the cost to themselves, and that makes them feel that they're part of something much, much greater than they are themselves. And if they feel that, and if their morale is to endure, it must have certain foundations: spiritual, intellectual, material, in that order of importance. Spiritual first, because only spiritual foundation can stand real strain. And I don't mean spiritual necessarily in a religious sense, so much as belief in the cause. There must be a great and noble cause. And what greater cause than universal free healthcare at the point of delivery? And people must feel that what they do really affects the achievement of that cause. And that's everybody, whether you are at the very top of the organization or you've only just started at the bottom of the organization. Intellectual next, because people need to be swayed by reason as well as feeling. They must be convinced that the object can be attained, that it's not out of reach, that the organization to which they belong is an efficient one, and that they have confidence in their leaders. So we come back to trust and competence. And finally, material. Now that's important, but it comes last because sometimes the highest morale is found when material conditions are at their worst. People must feel they're going to get a fair deal from their leaders and from the organization generally. They must be given the best possible tools and equipment to do the task, and working and, if necessary, living conditions must be made as good as possible. But we make it easier for ourselves in the Army with that culture of the team, that cohesion and mutual support which an individual gets from his section, his tank crew. his battalion, his company, or whatever organization he or she is part of. It's that feeling of belonging to a band of brothers and sisters which fosters high morale, which encourages and brings on the less strong, and strengthens the feeling that people would do anything rather than let the team down. And that, in my experience, when the bullets start flying, is the key factor which overcomes fear, because everybody is afraid. Of course, soldiers need to know why they are fighting for Queen and country, but at the end of the day, they don't fight for Queen and country, they fight for their mates. So in my world, team building is about motivating your people through a shared sense of purpose, developing cohesion through building and fostering that sense of identity and pride that your team is unique and special. And part of this is the sense of shared values, shared goals, and interdependence, as in a sports team, when the weaker player, the weakness of one player or one section can be offset by the strengths of others. Building respect and trust, of course, always based on competence. And raising standards through training, through education, and development of both the individual and collectively the team. Empowering, not telling people what to do. Set the strategic conditions, set the overall intent, tell them what you want them to achieve, give them the resources, and let them get on and use their initiative. Because somebody who is at the sharp end will always understand the conditions than somebody who is sitting back in a remote headquarters or head office. Reward initiative and success, but hold people accountable for failure as well. It's about cooperative planning. No one, certainly in my experience as a senior officer, especially senior officers, have a monopoly of good ideas. So the key is to harness the brain power of the team in a relaxed and free discussion, a bonding process in its own right. I used to say that rank has no privilege, except at the end when a decision has to be made. And that's where leaders earn their pay, stepping forward and taking the tough decisions. And we come back then to moral courage. And as in any high-performing team, no leader should forget that he or she should be the exemplar of high standards in all respects. It's about doing the right things for the right purposes. And then there's strategic leadership. And if strategy is about balancing the ends, ways, and means in the pursuit of policy, other and higher skills are required, for simple rules or principles of decision-making do not necessarily serve one well in complex situations where there are no right answers, just limited choices between the least wrong ones. So clarity of thought, vision, adaptability exemplify the strategic leader as much as resolution and determination. An ability to live with ambiguity and uncertainty, and not least a pragmatic capacity to take a calculated risk for the longer term and greater benefit, distinguishes the strategic leader from the tactical operator. So strategic leadership, ultimately, is about leadership through influence rather than leadership through authority. Well, you're here to look at how systems can generate and sustain quality in healthcare. If I may, I would say that from my background and experience, I'd say that while, of course, the system is important, and systems are important, and it's good management which ensures that those systems operate effectively, ultimately, it is all about people as part of that system. We've all heard the cliche that people are our most precious asset. I'd say that's rubbish. That chair's an asset, that table's an asset, that speaker's an asset, that sits on the balance sheet or the register. People are the organization. People are the systems. So if you want to improve your organization, and this applies in any sector, you have to have the right leadership. That's where, I would suggest, the Resilience Plus comes from. That's what unlocks the creativity and the genius within the organization. And that means that it must be absolutely clear who is in charge, who is the leader, and who, therefore, is responsible for the decisions that affect people directly. Your people must know, and they must trust the leader. They must know and buy into the core values of the organization. And your leadership must be able to inspire, communicate, connect with people, if he or she is to take them on the journey. Ladies and gentlemen, enough from me. I hand now back to the chair. Thank you.
Richard, thank you so much for a wonderful start to our day. And it's my pleasure now to introduce our next speaker, who is indeed from this sector. And he, Jan Filchowski, has undertaken a number of NHS CEO and turnaround roles. So, colleagues, please put your hands together and welcome Jan.
Well, good morning, ladies and gentlemen, and thank you very much indeed. I would like to pay tribute to what Richard said. There were a number of things there that struck really big chords, and I hope I'll touch on them in talking a bit about the NHS as I've experienced it and as it is now. Before I jump in, I cannot resist making a couple of comments about the topic of the day. If we look up there, let me, systems. I want to touch on the point, which system are we talking about? Is it the NHS, or is it the 500 organisations that comprise the NHS? And in what sense? Is it a system, or is it 500 systems? And in particular, do we allow an undeclared ambiguity and ambivalence stop us thinking clearly about what system needs to do what? I guess the other thing that struck me as I was reading the theme for today was the slightly convoluted phraseology. Sustaining quality improvement. Now that could mean a number of things. Does that mean sustaining the improvements we have made? Or does it mean sustaining improvement, i.e. continuing to improve? And is that a linear thing? Is it a stepped thing? And indeed, the idea of sustaining suggests that you perhaps can't go backwards, and I would also like to put the proposition that you can go backwards as well as standing still and going forward. So let me then start as quality is the watchword today, and I would like, if I may, to quote from a poem, one of, I think, probably the two most famous poems by one of our great poets of the 20th century, Philip Larkin. And I think you may recognise the first line. Sexual intercourse began in 1963, which was rather late for me, between the end of the Chatterley trial and the Beatles' first LP. It fixed something, didn't it? And for me, quality began in 1989. I don't think anyone talked about quality or thought it was a topic that merited separation in discussing how we managed. And we did discover at that time that quality was something in itself we had to pursue. We had no idea how to pursue it. We looked at America, where it had been pursued for some while, and we set up quality departments which were separated from the mainstream of what we did. And then we started accrediting in the 90s. So we discovered it, but we didn't know what on earth this strange beast was. What I also want to say was, I think we discovered it at a time when there was a revolutionary leap forward in the way we managed. I think we frankly, in the second half of the 80s, discovered management in healthcare. Before then, it had been an administered service, one which broadly went on autopilot. And by accident, an accident's a thing I'll come back to, the government brought in a man to look at manpower in the NHS, and he said, you can't look at manpower, you've got to look at management. And that was a guy called Sir Roy Griffiths. The Griffiths report, in my view, the best report in my whole career in the NHS, a mere 14 pages typewritten. And there are two phrases which I'll never forget from that. First one, if Florence Nightingale was walking around our wards today, she would be asking, who is in charge? And of course, his answer was, and we all knew it was the correct answer was, no one was. Because we didn't believe in anyone being in charge. And he precipitated that change. The other one I remember from that report is, if you think of the NHS, it's like one of those large bouncy castles that you see at a fair. You jump on it, you push it out of shape, and after a while, it returns to the shape it started in. I think both those quotes are absolutely relevant today. Changing the shape of the NHS, finding a step change is something we're failing to do at the moment. And it is also my contention that at the moment, to the question who is in charge, the answer is either no one or we don't know. And we need to correct both those things. So let me come back to quality. I think in discovering quality, we realised that first of all, and I think there are two basic things. One of the things you absolutely must do. If you do not do them, you fail. So you either get rid of an infection or you don't. You can't nearly get rid of an infection. And these fundamental things we have to realise, and we keep recomputing. But I think it was the Bristol heart surgery disasters that taught us that. There are certain things we absolutely must do and cannot get away from and should not. But what we also started to learn, and I think for me the second great revolution in my time, which was the revolution in the 2000s, again I don't want to precisely say when it started, and we'll come on to whether it's ended, one of Jennifer's themes, and that's the improvement revolution. And I think that's another one we stumbled into. But let me first of all talk about it in relation to quality, because we started to realise that performance wasn't just a black and white thing, that there were shades of grey, and that what you needed was some measure of performance. You know, was it all right for people to wait 2 years to have an operation? Or was 6 months the maximum that was reasonable? You know, how long could people reasonably stay on a trolley in a corridor waiting for admission to an acute hospital? Was 4 hours waiting to be treated about right or rather too long? And what I think we realised, and I think rightly started to drive us, was that it was important to have measures. And these are things which change and evolved. And some of these are very well known and some are rather less well known. And in the early 2000s, when I stumbled into a failing trust and tried out some new improvement ideas, and I remember thinking, God, this is a failing trust. I've tried out these new ideas I happened to pick up when I was in Harvard. I hope to God they were, because if they don't, I'm finished. And actually, they did start to work. And then I started to get involved in turnarounds. And what I realised was the reason why organisations quite generally were getting into trouble was that they were measuring what they thought they needed to achieve on their own terms, rather than on the terms of those who actually, legitimately and powerfully, were making the judgment. So at Medway, when I went there, my predecessor had been sacked 2 months before I arrived, a month after the new hospital opened. The new hospital had been what they'd been seeking to achieve for several years. And they decided that that objective, that was the measure of their success. Unfortunately, that wasn't the view that others took. The government, the regional health authority as we then had it, and indeed the public in some ways, because waiting times were appalling, there was chaos in A&E, and the savings that were supposed to be made were not being made because the people who, the rationalisations that were supposed to be made were there in lovely new buildings, but they'd omitted to close the old ones, so they had lots of double running costs, etc., etc. And so what I also realised was, and then when I was brought into Bath by the Secretary of State 3 or 4 years later, and it's a lovely place, Bath, as I'm sure you know, and it actually is able to attract very good doctors. But a month before I was brought in, the Secretary of State had described it as the worst hospital in the country. The Secretary of State in the House of Commons. Not good. So there must have been some reason why he said that. So I go there and the doctor said, well, we can't understand it. Dr. Foster's just published its ratings. And our SMR's the lowest of any DGH in the country. We're clearly a successful hospital. But they knew that wasn't so. They knew that the other measures mattered. And they knew that when they went to their national colorectal meeting, all the other doctors saying, oh, you're in Bath. Oh, dear. So I think a really important thing about quality is understanding the metrics. And if we do that, we aim at the metrics around which the system is constructed. There's then the issue of whether they're the right metrics. I want to move on to aspects of management and leadership, and I would like to bring out for later discussion the issue of management or leadership. I'm a great believer in the importance of management. Leadership matters in certain situations, but if you're not a good manager, you won't be a good leader. And I think we need to remember that. I think improvement science has been great in helping us to reinforce and understand that, and that our skills need to change. And I think Richard said something about this, but our skills as managers need to keep changing and altering, because as the measures alter, what we need to achieve them alters. So the old task of a manager when I got involved was you just kept things going and moving. And then we said, well, it's not good enough. It's not good enough to have weights. Okay, we have to find ways of getting rid of weights. And I remember in the early 2000s when I was leading national task forces, going to places and say, well, we can't do it. We need money. It's just a question of money. If we had more money, we'd have no weights. So we examined their weighting lists and said, well, you actually got this massive weight in orthopaedics, but actually you haven't. You're dealing with shoulders quite well, you're dealing with hips quite well, you're dealing with ankles quite well. You actually are unable to deal with knees. And part of the problem is your knee surgeons are doing ankles, hips, and so on. So why don't you get them to do knees? Why don't you get everyone else to do the other stuff? And why don't you stop them seeing outpatients till they've cleared all the inpatients? Problem this big becomes this big. And then you say, okay, that's a real problem, send those off to the private sector. And I know in 2 cases where we found something like that, effectively, management realised they were getting it completely wrong. And in both cases, actually, not that long after, and it was not doctor death, but both chief executives fell on their swords as a result of that. They hadn't learned the skills they needed. So we need to keep changing and learning skills. I'd like to say something about people. People are absolutely at the centre of what we need to do. And in organisations like the NHS, you really cannot command and control. You have to win support. People need to believe you've got an understanding of the problem, and then they'll go with you. And all my experience is they've got the answer if you can catalyse it. In this room, there's thousands times more expertise than I have about the NHS. And in a discussion we're having, if we can bring that together additively, we create much more power. And all the best things I've done have been actually accessing that. When I went to Medway and we first dealt with waiting time, the answer was already in the people. And I remember 2.5 years later when I got the Secretary of State, I'd been told by Barbara Stocking, who was then head of the region, she said, from our point of view, everyone in this place is universally mediocre. You have to change that. 2.5 years later, when we changed it round, Secretary of State got up and said, I was wrong. This is a place bristling with innovation. And I looked around and I thought, these are exactly the same people. All we've done is enabled them to deliver, given them the tools and, to use Richard's phrase, trusted them. That's really important. Now, I'm going to have to bring this to a quick end, and there's lots more I'd like to say. I would like to finish on an issue of happenstance and chance, because I'm not really a believer in chance. We'll all have good and bad luck, and we have to learn to ride our bad luck and jump on our good luck. But usually, in my experiences, what we describe as luck or chaos is what we haven't bothered to understand. And if we look at the journey the NHS is through, we can't do anything about waiting lists. Oh, yes, we can. But A&E emergency admissions, that's much more chaotic. We can't do anything about that. Oh, yes, we can when we get a different system. Oh, we've got a problem with infection control. We can't do anything about that because infections don't take any notice when you tell them to stop. Oh, yes, we can. We can find a way of classifying and grading and dealing with that. And I love Napoleon's phrase in that regard. He was asked why his generals were so lucky. And he said, I only appoint lucky generals. I'll tell you later a story behind that. I'd like to finish where I started on where the NHS is. I think at the moment, real problems. I don't think we know who is in charge. I don't think anyone's in charge, and I think that's a fundamental problem. How can we have a 5-year view that everyone lauds, and 2 months later, the worst crisis in the NHS that wasn't even mentioned in the 5-year review? And ambiguity as to whether NHS England has got any responsibility at all for what's going on. And I don't think that's okay. I think we need leadership and accountability. And what I think we lack at the moment, and it's something I've sort of got an understanding of in the last few months, thinking about this for a programme I've been preparing for Newsnight, what the NHS has at the moment is a defective business model. And what it needs is a business model that works. Now, business model is relatively new thinking in the NHS. And the business model we have is what I would call the pressure cooker or dustbin business model. There's the money, sit on it and cope. Oh, and we might throw in the requirement for 1 in 12 nurses in every ward, or 1 in 4 in A&E, which might cost a couple of billions, but the lid's staying on. Cope. And of course, at a certain point, you cannot cope. So what do you get? You get failures, you get explosions, and you get queues. And haven't we got queues here, there, and everywhere? And I don't think we need them. What we need is a different business model, a flow model that takes account of the fact that we remain one system, not that we flow and then create a queue and block, and then flow and create another queue and block. And I think we can do that. And I think that's the challenge for improvement science right now, to change that thinking, to get us to a different business model, one that will sustain us for the next 10 years. Thank you.
Thank you very much, Jan. Thank you very much indeed. Now I'm going to invite you to step up onto the stage. So thank you both extremely much for that. And I want to start, Richard, by asking you if I could, as you listen to Jan there, what are the similarities and differences that you were picking up in Jan's description of leadership and indeed the business model in the NHS from your experience?
I think there were many parallels between what I was talking about and what Jan was talking about, and those won't be lost on people. I think the one piece that comes out strongly, I think, is this business of trust your people, empower your people. Give them the intent, let them get on and work out how to achieve things themselves, rather than in some form of sort of Stalinist model decreeing what must be done. And I wonder if that's something that needs more development. But I think it absolutely comes back to the whole business of people and leadership. And we might pick up the difference between you management and leadership. Yes, I think yes. As a leader, you've got to be able to manage the systems. And in my world, that means you won't get the appointments unless you've proved yourself as a good staff officer. But I think leadership requires something more than that. It's leadership which sets the tone, the intent, and then the management gets on and makes it happen. But without the leader, I don't think you can achieve that. And the other piece I would just pick up on is this knowing your leader. And I mean, if an organisation doesn't know who the leader is, I think you've got real issues.
In a profession famously known for its command and control, you left us, or at least I heard you leaving us, with actually good leadership is about influencing, not commanding. Is that where you wanted to leave us?
What I would say, what I'm looking to do there is draw out the difference between what you might call the warrior leadership that at the tactical level in my world, the need to lead from the front, the leadership through authority, the need to inspire soldiers to do what you ask of them. But at the strategic level, it's more complicated than that. Because, and not just necessarily at the strategic level, but at the higher tactical levels, because you're dealing with multiple stakeholders, because you're trying to achieve things, and it may be that what you are trying to achieve depends on the actions of somebody over whom you have no authority. So you can't just say, do that, and it is done. It doesn't work that way. I mean, I go back to operational experience in southeast Iraq, where as much as we put together a major operation to try and get back Basra from the militia. Now, we could target the militia, we could conduct intelligence-led operations, and we could strike. But part of the operation was the application of economic effect, and that required the ability, the need to influence other stakeholders, non-governmental groups, diplomats, aid agencies and the like, in order to apply economic effect. And that is where the leadership through influence comes in. Yes. And I think that's something else that may be applicable in the NHS.
And you also ended on a note of strategic leadership, and two of the attributes you described were risk-taking and living with, or being comfortable enough with ambiguity. And it was fascinating. I mean, that's, in a sense, those are quite close to some of the NHS leadership qualities. They're quite close to what improvement scientists might be striving for. How does the Army get to that position?
I think it's so much about training and education. You train for certainty. You train for the science of war. You educate for the art of war. You educate to understand, and broadly, you educate to cope with the complexity and the chaos that confronts us. And we live in a complex, chaotic world, and it's as applicable on operations in war as it is in peacetime in complex organizations. And that requires training and education based on experience, and then the selection based on character and flair.
I'd love to come back to that, but just pause for a second there. Jan, what can the NHS learn from the kind of stories that Richard was telling us?
A huge amount. I think that there clearly is commonality. I think unity of purpose is very, very important. and I think we often don't have that. I loved a lot of what Richard said, particularly the Theodore Roosevelt quote. I thought got it precisely. And I think it's about trusting and doing. We have to be willing to act. And I think we have to act as a single tribe. I do believe it, in terms of 1989, apart from the fact we discovered quality, I think it was also the year that the Berlin Wall came down. And I think another Berlin Wall now needs to come down in healthcare, because I think it's a very Soviet word, actually. I think our experiment with commissioning has failed, and we need to end it. And we need to value, instead of setting up tribes of commissioners and providers, see ourselves as at one. And I think we will get a lot further if we do that. I think a lot of what Richard was saying, I would agree with. The NHS is, the fourth biggest managed organisation in the world, allegedly, after the Chinese army. I think it's Indian Railways and Walmart. And according to Peter Drucker, hospitals are the most complex managed organisations in the world. So hey, it's going to be pretty hard to manage this stuff. So to do that, we have to admit we're going to get a lot of things wrong, and there's got to be an ability to accept that. A phrase I picked up from a management guru in the 90s, a culture of forgiveness, not permission, because that's the only way you can do it. That's the only way you can act. And getting people to try things, to do things, to get more right than wrong. Because I guess when you're engaged in a battle situation, you have no alternative but to respond to events.
Yeah, I think there's another piece here, which is learning from events as well. And the military has to be a learning organisation. And at the moment, I don't think it's very good, actually. I mean, I think the whole business, you'll have seen all the fuss about the failure to publish the Chilcot report, for example. And when you have had, and self-evidently, and I would hold my hand up, Iraq and Afghanistan were complex operations which did not go as well as they might have done in a whole range of areas. Until you're prepared to learn the lessons and really drill into the detail, and this actually requires, I go back 100 years after the Boer War. What happened? Top to bottom, politically led, the Isha report, examined what went wrong, and the result of that was setting up the system of the systems in Whitehall that effectively have stood us pretty well through the rest of the 20th century. The General Staff, and the result of that was in 1914 the best trained army that Britain has ever sent abroad to fight a war, because there can be no redemption without confession, and people have to front up and learn the lessons rigorously and then apply them. So I think that business of being part of a learning organisation is critical. Let's go back there if we might. Colleagues in the room will be only too familiar with, after the Staffordshire Mid-Staffs disaster, various reports. We tend to, something goes wrong and we wait a bit and then we publish a report. And one of the findings of the Berwick review of that was that learning was key. Absolutely the point that you're making, but that's quite an abstract concept to many people. I'm really interested, and I suspect some people in the room are interested, how do we make learning so normal, so much the Monday morning part of your job, that it's unavoidable, that you can take risks and you can make mistakes and you can learn from it? What's the leadership or management role there to cause that to happen? Well, this is where I think the parallels become difficult, because it's one thing to make mistakes on training and not to be afraid of making mistakes when you're training. But you don't have that luxury. You can, clearly, in school, but you make mistakes and patients die. And it's a little bit, the parallel is that you're on operations all the time. We're only on operations some of the time. And we can afford to make mistakes on training and then hope not to make so many mistakes on operations. And when mistakes are made on operations, yeah, people die. But the learning piece you can build that in as well as from the top down. I mean, I'm talking about, my earlier point was in a sense a strategic point about the need to change the system and improve. But you can also, there's a bottom-up aspect here, which is that everything you do has in it an after-action review. How did that go? So I don't know, there's a major incident. At the end of the major incident, you sit down, you work out what could have done better, what could have been done better, where things went wrong, how can we improve the system? But that's a part of culture, and culture comes back to leadership.
Okay, and Jan, from your perspective, after-action reviews, critical incident reviews, how do you make that normal in the organisations that you lead?
I think what you have to do is to accept you're never going to get everything right, that there is never an end point. And I think a lot of management books, some of whom I sort of imbibed and liked very much in the 90s, In Search of Perfection, From Good to Great, I think they mislead us. And I think the aim is to be good, but to be better the next day. And I think this is some of what that title, which I was pulling apart, is rightly seeking to pin down, that if we accept that there isn't an end point, that we've got to try and get better having done something well, then there'll be something else that we're not doing well. And again, I'm not sure about the parallels here, but it's about the flexibility, and I believe we need to be ideas-led and not ideology-led. And it is a problem for the NHS. I think, although I've said we're not sufficiently unified, I think we're too ideological. And I think certain ideas become ideologies, and then we're not allowed to say, but actually in practice I found this doesn't work so well, I want to do something else. I mean, dare I say it, the belief that if we close 3/4 of our hospitals and treat everyone in the community, all our problems will be solved. That is an ideological view for which there's very little evidence. And what we need to do is to test those things out and pursue them where they work, and go somewhere else where they don't. And what I found in everyone's view of failure and success is that people, at a very crude level, people regard failure as a state. You've failed your exams, you've failed them forever. And success is a point. You've succeeded, you've won that gold medal at the Olympics. And to manage sustainably, we need to turn those two perceptions over. So failure is something that we get to and then we get out of by doing things better and better. But there isn't an end point. We have to keep doing things better and better. Otherwise, we'll drop down into failure again.
Thank you. Something you both touched on in different ways. You talked a lot about loyalty to your mates, in a sense, and you were, Jan, exploring the plural concept of teams. And I wonder, Health Foundation is very committed to notions of shared leadership. I wonder how, as we think about resilient systems, what's the role of the team, and what's the sort of middle level of leadership, and how do we encourage and cultivate those capabilities? Richard, how does the Army do this?
By having leaders at different levels, right from the lowest level of take an infantry section of 7 or 8 men will be commanded by a corporal, and 3 of those sections come together and will be commanded by a platoon commander, and then a company. At every single level, there is responsibility and leadership, and so leaders are empowered, and you won't find a company commander who's a major trying to do a corporal's job, because he trusts he will trust that individual to get on and do it within the overall intent. Holding people responsible, and so you've got leadership, but you've got the team cohesive at every level, and that builds up in a sort of series of building blocks to form an overall whole.
And how do you train, or how do you provide the learning for those individual leaders as they move through the system to know how to get the best out of their team? And you use the which is lovely. You used the expression EQ, emotional intelligence, which again is not necessarily automatically, perhaps stereotypically wrongly associated with military leadership, but yet you were very proudly and clearly using that phrase. How do you encourage men and women to be emotionally intelligent in that regard?
I think the bottom line, of course, is that the Army Act 1955 gives authority. And if I say go, you go.
Like jump.
And you turn to the right and you get on with it.
Yep.
We all know that point. But you would hope never to get to that point. And I think my experience is that if you've got quality people, and we have got really quality people, and if they want to do, and they're there because they want to be there, they're there and they want to do things well. So in a sense, and it comes back to the morale thing, if morale is high, people almost lead themselves. And I can say without absolutely any doubt at all, I've gained much, much more back than I've ever been able to give in return as a leader. Much more back from the people I have been, in a sense, responsible for. And the EQ thing comes, it is about, it's the art and science thing as well. And it's about that ability to tap in and resonate with the people that you're working with and the people you command.
I think you said at one stage, I hope I'm not misquoting you, that morale is often best when you're in the worst possible situation. We've had a fairly trenchant discussion and description of the NHS at the moment. Is there any advice you might give the NHS, which may, you're being very kind to it, which may not always feel that its morale is very high? How might colleagues in the NHS improve their morale? What's the leadership role there?
Well, I think I said that of the three foundations, material comes last.
Yes.
Because sometimes morale is high, and when material conditions are worse. Because actually that's when you feel, you feel that if conditions are bad and the team is pulling together, you sort of feel a sense of pride that you're overcoming the cold, the wet, the dirt, the discomfort, the danger, and it bonds the team together. You asked me to give advice for the NHS. Well, I think I would ask a number of questions. If I go and talk to a kitchen porter in the West Suffolk Hospital, Bury St Edmunds, where I once did a holiday job as a kitchen porter, does he feel, to what extent does he feel motivated by the core values of the NHS? If I go and talk to a doctor on casualty, does he or she know the core values of the National Health Service? Last night I spoke to a consultant ophthalmologist who didn't know who the chief executive of the NHS is. If I Google Simon Stevens, I find that he describes himself, always described on Wikipedia, as a health manager and politician. I question, does that send the right message to people in the NHS that this is a leader? Just a few questions that I might pose.
Beautifully poised, elegant questions, but sharp at the same time. How do you react to the team issue and the morale issue, Jan?
Well, I do think a leader's role is to assemble and motivate a team, and with such a large organ, I mean, certainly if you're managing a trust, I think that has to be done in concentric circles. And I remember my first chief executive job at Poole, when we were trying to become a trust, the equivalent now of a foundation trust in the early 90s. And the BMA, the august BMA, said, we're completely against it. A number of doctors wondered if it wasn't a good idea because it gave us massive freedoms. And so there was a vote of the doctors against it, and I, as the new chief, said, I will not make us a foundation, a trust, until there's a majority here. So what I did, I convinced the medical director. We then got 5 or 6 key doctors, convinced them. Then we met in groups, spending as long as ever with groups of doctors by specialty. And it took us about 2 years till that was talked through and convinced. And we had a vote 2 years later, 95% in favour. And I was particularly proud of that because the chairman of the BMA was one of the 5%. So I think it's about convincing, understanding, bringing people along, and then empowering people to take things forward. So to create leaders within the organisation. And again, at Medway, when we people started to see we were changing things and the top was committed. I got a junior manager in X-ray saying, you know, we've done all these things in inpatients and outpatients. I think I can get rid of the weights in X-ray. And I said, oh, can you? And then, so I said, okay, we'll support you. 3 months later, they'd all gone. It was about empowerment. The insight and the knowledge was there when people believed they would be part of a winning team.
Great. Well, colleagues, we're nearly at the refreshment break, in case you're worried that we were going to go on talking over our refreshment break. And I've got one more question for both of our speakers, which is really to give us any questions they'd like us to return to after the break. Our topic is resilient systems. Our topic is how to create the energy for improvement in both of the senses that you were talking about, Jan. What questions occur to you when you think of the role of leadership and leaders, however you define that you might like to throw into us? We've got about 20 from Jennifer already, which we shall attend to. What would you like us to think about? Jan, what question?
Well, I think it's very important within the NHS to say, as a leader, what is in my control and what do I need to respond to that is outside my control, and to understand that and not fall back on ambivalences and ambiguities. So I think that's very important. And the question I would ask following on from that, do you see the NHS as one organisation, and should it be, and what accountability should flow from that to make it work?
Thank you. Richard, what questions would you like us to consider?
How are you training and educating your leaders throughout their careers?
Great. Colleagues, I think that was a wonderful tour de force from both of our invited speakers. Would you join with me, please, in thanking them both in the normal way?